Hi everyone. So in the previous video of the thyroid Viva questions, we discussed about the ultrasound, thyroid classification and U classification of ultrasound. And in this video, we will discuss the FNAC classifications of thyroid swelling. So there are two main classifications of FNAC. One is Thai classification and second one is Bethesda classification. Basically these two are same, but there is only difference of one subclass. So we see we will see in this picture that Bethesda classification is subdivided into 6 subclasses, and the Thai classification is subdivided into 5 classes. So in the Bethesda 1 is non-diagnostic, Bethesda 2 is benign, Bethesda 3 is flush, which is follicular lesion of unknown significance. Note that in Thai, this subclass does not exist, and this is the main difference of Thai and Bethesda classification. And next is Bethesda 4, which is a follicular lesion, and Bethesda 5 is suspicion of malignancy, and Bethesda 6 is malignancy. So you have to remember the risk of malignancy in each subclass, which is very important. If there is the Bethesda 1, which is non-diagnostic, there is still the risk of malignancy, which is 1 to 4%. Okay, in this case we will repeat the FNAC in Bethesda 1 and in Bethesda 2, which is a benign subclass, but still there is a risk of 0 to 35%. And we will follow up with ultrasound and FNAC after 6 months. And we will not do any surgery until there are any compressive symptoms or cosmetic lesions. And in Bethesda 3, there is a risk of malignancy which is 5 to 15%, and there are 3 management options, which are FNAC, molecular testing, or the diagnostic hemithyroidectomy. In the Bethesda 4, which is follicular lesion, this is also there is also a risk of malignancy which is 15 to 30%, and we will do diagnostic hemithyroidectomy in this case. In Bethesda 5, there is suspicion of malignancy, which is 60 to 75%, and we will do total and near total thyroidectomy in this case. And in Bethesda 6, which is a confirmed malignancy, then there is 97 to 99% risk of malignancy in this case. So we will do total thyroidectomy in this case. So the Viva question is, what is the sensitivity and specificity of the FNAC in thyroid swelling? It is highly specific and sensitive. Its sensitivity is 70 to 98%, and its specificity is 70 to 100%. Okay, next investigation in this solitary thyroid swelling is thyroid scan, which is thyroid scintigraphy. So there are many indications of thyroid scintigraphy, which are the toxic multinodular goiter. The second one is to differentiate between hot and cold nodule, as we will do in this case. And the third one is congenital hypothyroidism. So if there is a solitary thyroid nodule, and we will do the thyroid scan in this case to differentiate whether it is hot nodule or whether it is cold nodule. If it is hot nodule, the risk of malignancy is only 1%, but if it is a cold nodule on thyroid scan, the risk is 8 to 25%. Okay, what is the gold standard? Gold standard is still FNAC. And what are the other tests we will advise our thyroid, which are the thyroid function tests. In thyroid function test, the tests included are FreeT3, FreeT4 and TSH. First test is always TSH in thyroid function tests. So other thyroid tests are anti-thyroid peroxidase antibodies. What are the indications of anti-thyroid peroxidase anti-TPO antibodies, which are one is autoimmune, which is most important, in which there can be Hashimoto thyroiditis, there can be Graves disease. In both these cases we will do anti-TPO antibodies. But the in the Graves disease, the more specific is TSH receptor antibodies. Okay. Okay, there. What is the difference between solitary nodule and adenoma, which we have already discussed this case, this question? What is colloid nodule, and what is the management of solitary thyroid nodule? Okay, this is important. So we will manage the solitary thyroid nodule according to the investigations, according to the FNAC, according to the thyroid scan, and if there is a carcinoma, cosmesis, or compressive symptoms, then we will go to surgery. And what is the management of thyroid adenoma? Uh, Benign thyroid nodule. The management of thyroid adenoma is according to Bethesda. It can be a general simple adenoma, which is benign Bethesda 2, and it can be a follicular adenoma, which is Bethesda 4. If it is simple adenoma, which is Bethesda 2, then we will just keep it on follow up with ultrasound and FNAC after 6 months. If it is follicular adenoma, then we will go for surgery. And if there are also compression or cosmetic reason, then we will also go for surgery. Okay, the other thing is that if you advised uh, TFTs, and on TFTs thyroid function test there is hyperthyroidism, then how will you manage this case? We will first manage the do medical management for hyperthyroidism. And what are the medical management options for hyperthyroidism are carbimazole or propylthiouracil. Okay, what is the dosage of carbimazole and propylthiouracil? Uh, the dosage of carbimazole is initial 20 mg daily, and propylthiouracil is 200 mg daily. The maintenance dosage of carbimazole is 5 to 10 milligram, and the maintenance dosage of propylthiouracil is 100 milligram. We will do follow up on every 4 to 6 weeks, and then taper according to FT4. And this is a very important question, that what are the side effects of carbimazole? The side effects of carbimazole are pruritus, vasculitis, liver damage, and agranulocytosis. Agranulocytosis is very serious side effect of using long-term carbimazole, and it is actually when the absolute neutrophil count falls less than 500 cell per microliter, we will simply withdraw the drug, and the symptoms will resolve in this case. So this is all about the management of hyperthyroidism in a case of thyroid nodule. Then what is the management of hypothyroidism? If on TFTs you advise TFTs, and on TFTs it shows the hypothyroidism, then the option is levothyroxine. Thyroxine dosage is, if it depends on the age and cardiac condition of the patient. If a patient is less than 50 and 50 years old and there is no cardiac disease, then 100 microgram daily, we will start with 100 microgram daily. But if the patient age is more than 50 and there is a history of cardiac disease, then we will start with 25 microgram daily, and then we will increase every 4 to 6 weeks according to the thyroid function tests. Okay, this is all about the management of the solitary thyroid nodule. uh, I hope you like the video. Thank you.